confidentiality, office-based opioid treatment. I think this is the first time we're actually doing this talk. So it's sort of the trial run or inaugural run, but a lot of new changes have happened. There's no disclosures either in the past or in the present for me to make. We're going to recognize the spirit behind confidentiality regulations pertaining to opioid use disorders, buprenorphine treatment. Then be able to discuss some of the pros and cons of the heightened confidentiality requirements. And finally, kind of go over the basics of 42 Code of Federal Regulations, what's often called 42 CFR Part 2, which kind of govern our practices, right? So we're going to talk about that. And I also want to talk about some major changes, major revisions that were made last year in 2020, and some major changes that actually may be coming not too distant future as part of the CARES Act that was passed by the Congress in 2020. And these, so I think what's changed and what might change in relatively recent future. So those are some things I want to talk about. So starting with the spirit of our confidentiality regulations, and I kind of begin with sort of, this is the Hippocratic Oath has been revised several times, right? Believe it or not. Most recent revision, I think, was the one that often we all recite, was, I think, done in the 1950s. So it's actually a relatively new thing. But as part of the new Hippocratic Oath, one of the lines in it is, I will respect the privacy of my patients, for their problems are not disclosed to me, that the world may know. And I think that really lies at the heart of our confidentiality regulations, right? The spirit of regulation. So I think we've talked about this before, and we've even done an entire session on it and do it as part of our core curriculum each 3-month cycle about how substance use disorders are highly stigmatized. In fact, they are probably the most stigmatized group of illnesses, right, that we encounter, and our patients are tremendously affected negatively by it. And we know that stigma and fear of prosecution may in fact deter an individual from seeking treatment. And Congress recognized this. And the deliberations around passing some regulations specifically around protecting the privacy of individuals seeking treatment for substance use disorders, those discussions began in Congress as early as 1971. And ultimately, the first original version of 42 CFR Part 2 was actually passed in 1975. And the first then the revision happened in 1987. And then those laws stayed static for another 3 decades until things started undergoing a lot of revision in the last 3 years or so, right? So these laws have been with us for a long time, and they're intended to protect the privacy and confidentiality of individuals seeking treatment for substance use disorders. And it is the cornerstone of treatment and privacy in case after case, right? If you look at even legal precedents, it's been upheld that privacy of our patients is of utmost importance. And it is the higher level of privacy protection, right, compared to HIPAA, which is not the focus of this talk, right? It's a separate set of regulation that guides, many providers. Here I'm focusing specifically around the 42 CFR Part 2 regulations. And I think when we talk about the spirit, it's important to think about the setting from which these laws derived, right? 1970s, the beginning of the war on drugs. June of 1971, in fact, is when President Nixon declared the war on drugs. Increased size and presence of drug control agencies. And that actually was the beginning of things like no-knock warrants and mandatory minimums. Cannabis was placed under Schedule 1. So in public and in Congress, there was great concern about the potential use of a person's substance use disorder information by the government. And that's why these discussions started, right? And 42 CFR Part 2 was designed, again, in the original version came out in the mid 70s, to ensure that a person receiving care for a substance use disorder is not more vulnerable than a person not receiving treatment, because we recognize that patients with substance use disorders should be treated, and not treating them not seeking treatment, then not receiving treatment worsens outcomes for the individual as well as for communities. Patients are at potential risk, right? I think all of us can appreciate this, that breach of protected information can lead to things like civil, criminal consequences, loss of employment, housing, child custody, discrimination by providers, insurance, as well as legal proceedings. So these things are, as we can imagine, of great concern to our patients. But there are two sides of it, right? The second thing is like just starting to think about the pros and cons. So certainly it's very important to protect our patients' privacy, but we're often balancing that against the danger of fragmenting clinical information and clinical cares and thereby sacrificing comprehensive care. And that's sort of the battle, that's the balance that has played out over the years. Even if you look at the public comments, right? Um, from various professional organizations, from individuals around the 42 CFR Part 2 regulations, this is what you see emerge, right? And how do you strike the right balance between them? And I put this question for thought because that's something I think about a lot. So, for example, here at University of New Mexico, you know, status has changed, but unless the patient consents to it, right? My notes, right, as a substance use disorders provider, may not be visible even by other providers within the UNM system, right? It requires kind of special access. And I often think about that because my notes from Dr. Maley, Dr. Jacobson, people who work with these individuals often reflect the individual in a holistic view, right? My note might reflect that, sure, the person has opioid use disorder, but the person is also holding down a job, is raising a family. They've been resilient in terms of overcoming their and being treated for their post-traumatic stress disorder. So I think about it that can records from substance use disorder providers, rather than stigmatizing the individual, could they present a more complete human view of individuals, sort of the person first view? So I just put that out for reflection. Another note, and this is kind of based on a real case with all the PHI change, about the potential dangers of fragmentation of care. So Mr. X is a 42-year-old male with opioid use disorder and chronic low back pain. He is treated with methadone 115 milligrams daily at an opioid treatment program that's federally licensed under the 42 CFR Part 2 regulations until the revisions last year. Opioid treatment programs could not disclose within the PMP, the methadone dispensing records, right? So this has clearly happened prior to that. He goes to the clinic for directly observed dosing 4 days a week and receives take-home doses for the other 3 days. His urine drug screen, most recent, is positive for methadone, methamphetamine, and cannabis. He saw a new primary care provider on a Friday who started the patient on oxycodone APAP 5325 3 times a day for chronic pain. The patient did not come into the opioid treatment program to receive his methadone on Monday. He was instead seen in the emergency department after being found down by his 12-year-old son, and he responded to naloxone administration by EMS. And the patient reported later that his dose of oxycodone just wasn't helping the pain, it wasn't enough. And so, since Friday, he had been taking up to 20 milligrams 3 or 4 times a day over the weekend. And the primary care provider had no idea that the patient was on methadone because the patient did not disclose it, and methadone records do not routinely show up in the prescription monitoring profile. So I bring this up as sort of the other side of it, that sometimes this can create a real safety issue potentially for our patients. That brings us to the law, and we're going to dig into it a little bit. 42 CFR Part 2, again, protects the confidentiality of identity, diagnosis, prognosis, or treatment of any patient records maintained in connection with the performance of any federally assisted program or activity relating to substance abuse education, prevention, training, treatment, rehabilitation, or research. That's what the law says. So what does that mean? So first of all, what's covered and what's not covered? What does a program mean, right, under this definition? So a program, so first of all, it says it can be an individual or an entity who holds itself or herself or himself out or themselves out as providing substance use disorder diagnosis, treatment, or referral. It can also be a person within a general medical facility who holds itself out as providing substance use disorder, right? So a specific person or a specific program within a larger facility. It could also be, again, medical personnel in a general medical facility. So it could be a program that stands by itself. It could be a program within a larger entity, or it could be an individual within a larger entity. So what does holding self out mean? So it's defined as any activity that would lead one to reasonably conclude that the individual or entity provides substance use disorder diagnosis, treatment, or referral for treatment. So it could be through advertising or marketing or putting yourself out, right? Or the hospital website saying that, Dr. Jacobson is an addiction medicine physician, right? So it could be anything along those lines. Note that an ER physician, for example, who sees a patient in the emergency department and refers the person to ICU for overdose, right, doesn't fall under this, right? Because that's not the primary thing they do. If the primary thing the program or an individual do treats substance use disorders, diagnoses them, or prevents them, then chances are that it's covered under 42 CFR Part 2. And then it says federally assisted. So what does that mean? So it can be anything, right? And look at this. So if for example, a facility or an individual has license or authorization, like a DEA registration, it's federally assisted. If they're supported by funds provided by the government, like Medicare or Medicaid, grants, federally assisted, that criterion is met. If the program is tax exempt or claims tax deduction, the definition is met, right? So the definition is quite broad. And when in doubt, remember, I am not a lawyer. This is the, disclaimer that I give. Always consult the legal counsel of your organization because these things can get quite confidential. So HIPAA and 42 CFR Part 2, different set of regulations. There is some overlap, but most healthcare providers, reality is must adhere to both set of regulations. And if laws conflict, the law says you must adhere to the more stringent privacy requirement, which is usually 42 CFR Part 2. So again, HIPAA is more general. It's generally healthcare providers or health plans that engage in certain electronic transactions, but 42 CFR, the definition is again narrow, right? It's those federally assisted programs specifically holding themselves out as sort of working with the substance use disorders field. So what's, so in fact, the law around 42 CFR Part 2 is so strict that you can't even disclose, right? And HIPAA is not this strict, right? So under HIPAA, for example, you might be able to say that a person is a patient, but under 42 CFR, so at our clinic, we cannot even acknowledge that a person is a patient or has been a patient, right? Including in response to record requests. So we cannot do that without a court subpoena, a judge's order, right? Or there are some other exceptions, which I'll go over. You may not disclose any information that identifies the person as having had or referred to an SUD without the person's consent, unless an exception applies. So what are some exceptions without consent? So communication within the Part 2 program. So for example, I can send a protected message through our EMR to Dr. Maley about a patient because we're both part of the same Part 2 program, right? But I cannot send it to, for example, a primary care provider who does not work at our ASAP clinic, even if the primary care provider is a part of University of New Mexico, without the patient's consent, right? Medical emergency, reporting crimes or threats, but limit info, reporting child abuse or neglect, of course, research under certain conditions, and audit by the government or a court order. So very few chances where you can break that confidentiality. But when you do break it, 42 CFR also provides very important protections, right, to our patients. It says that the program information cannot be used in court proceedings, right? Criminal investigation without a court order. Undercover agents or informants cannot be placed in a program. And if it does happen, that information cannot be used in any criminal actions. So those are protections offered to our patients. These are the components of a consent form. Basically, it must say, right, who's going to receive the information, what's the purpose. It can be revoked anytime. It has an expiration date, date of signature. And there is a form on the, I've included a hyperlink that has a 42 CFR Part 2 compliant consent form that is available for public domain that you all may be able to use. Note this quotation. That is essential that your consent have this quote. 42 CFR Part 2 prohibits unauthorized disclosure of these records. So for example, if I send a group of records, right, to Rana, say, who works in a different agency, she cannot then redisclose or share those records with anyone else. So that's a very key piece of the 42 CFR protections. So major revisions have happened. It's about 12:22, so we're doing okay with time. Major revisions were happened, including just last year, right? So let's go into that. The first one is sort of around redisclosure. It actually clarified that treatment records created by non-Part 2 providers based on their own patient interactions are not covered by Part 2, right? Just segregate records. So what does that mean? It's meant to facilitate coordination of care. So that was confusing to me, so I just used a case. So say JH is a 42-year-old female receiving treatment for a substance use disorder at an opioid treatment program. She's treated with Suboxone 16-4 for opioid use disorder. See, she sees Dr. M for primary care. With appropriate consent, the OTP provider speaks to Dr. M. So say I got consent, I spoke to Dr. M regarding her treatment. But then Dr. M had her own independent conversation about the substance use disorder and documented it, right? So Dr. M talked about a substance use disorder, and she utilized some verbal information she had received from me in that conversation. But the revision clarified that because what I talked to Dr. M about was verbal, and Dr. M had her own conversation with the patient, her documentation is not subject to 42 CFR. However, if I had sent over some paper copies or faxed over some records to Dr. M, those records, those written records, the printed records, are subject to 42 CFR and must be segregated from general medical record. Another thing that the law said last year was around disclosures for care coordination and case management, where you no longer have to specify a specific person. Before, until last year, if I was going to get a consent, I would have to put a specific person's name on it, which got very difficult because we often don't know who that specific person might be. So now the law says it's okay just to list an organization. And finally, and very importantly, per the revision last year, opioid treatment programs can now report to prescription monitoring program, right? To avoid something like the case I reported at the beginning of the presentation, but this can only be done with patient consent, and the patient has a right to not provide that consent, right? Now, another major thing happening, this is sort of the last slide with information. So CARES Act, right, which was passed last year, of course, which is the Federal Coronavirus Aid, Relief, and Economic Security Act, signed into law March 27, 2020. That actually contained provisions. The Congress put in provisions to change 42 CFR further to make it align more closely with HIPAA, right? And it changed some major things. It is not effective yet. SAMHSA still needs to create regulations, right? So it might happen in the future. It needs to happen in the future. There's a lot of controversy around these revisions because in some ways it weakens the protection, privacy protection. So you can see that now, once this happens, a general consent is enough for disclosure of substance use disorder records. So as opposed to a 42 CFR specific consent, once this goes into effect, a simple general consent may be enough. It also very importantly allows that redisclosure, which is very interesting, which is that fifth bullet, may be redisclosed in accordance with HIPAA. So once this goes into effect, if I share some 42 CFR information with Rana, she may then redisclose it to someone else. So that really weakens the protection, and there's quite a bit of backlash against it and controversy around it. On the other hand, I think this also does some good things, right? Some positive things, aligning the two, HIPAA and 42 CFR, to make practice more, facilitate practice. It also specifically strengthens protections, says that the records from substance use disorder treatment can not only no longer be used in criminal proceedings, but also cannot be used in civil, legislative, or administrative proceedings. So that strengthens the protection for our patients. Also, makes an obligation to comply with breach notification. So if there is a breach of privacy, it must be notified, it must be reported. And it also specifically adds in protection against discrimination, based on intentional or inadvertent disclosure of substance use disorder records. So there are two sides to it. But nonetheless, Congress has passed the law, and now SAMHSA has to figure out how to actually implement this. So this is not the case right now, but may happen in the future. We've got about 3 minutes left. So I thought we would at least do kind of one scenario, right, to clarify some of these. I put in three scenarios here because I wasn't sure how much time we would have. So for discussion. So this is scenario one. So Dr. Van Buren is a physician at a ABC treatment program, which is a federally licensed, federally registered opioid treatment program. Charlie is a patient. Charlie had developed a back pain condition, has been treated by Dr. Harrison for some time. But before seeing Dr. Harrison, Charlie had developed opioid use disorder. So Charlie came to see Dr. Van Buren at the opioid treatment program, and now he's being treated with Suboxone, with buprenorphine at this opioid treatment program, right? And now Charlie has a follow-up appointment coming up with Dr. Harrison. So Dr. Van Buren talks to Charlie and says it would be really good to coordinate care with Dr. Harrison. Do you give us consent? So that's the basic scenario. So the first question here is, Dr. Van Buren and ABC treatment program, are they 42 CFR covered entities? And the answer is yes, right? Because they're specifically a program that provides substance use disorder treatment, and they are federally assisted, right? Because they're regulated by SAMHSA, right? They're an opioid treatment program. So therefore, ABC treatment program is a 42 CFR2 entity. So what that means is that for Dr. Van Buren to talk to Dr. Harrison, she must get consent from Charlie, a 42 CFR Part 2 compliant consent that talks about, she will talk to Dr. Harrison about her substance use disorder diagnosis, what the reason is, when it expires, and that Charlie can revoke it at any time, right? So that's just to give one idea. I am actually going to stop here. There are a couple of other scenarios that I think we can go over another time when we have free time.